Right. Good afternoon, and thank you for the organizers for welcoming us. I also want to thank my panel. Some of them have reviewed the slides in advance, but not everyone. So in case we disagree, it's with a good heart. So this Dr. Dash does not require any introduction to majority of you here. This is me. I'm in Mayo Clinic. I was trained in Rochester, but moved to Arizona. This is Dr. Raman, has been helping the Whitefield campus for a number of years, maybe perhaps a couple of decades. And Dr. Garg has worked in Puttaparthi and has moved to the US, but comes regularly to Whitefield. I want to talk on my topic. So this is how coronary artery disease, the life comes to an end. Ventricular fibrillation, if it is intervened within the first 45 seconds, the chances of recovery is about 99%. At about 2 minutes, it drops off to 80%, and at 4 minutes, even if you recover, the brain starts showing hypoxic, and at 8 minutes, you will have anoxic encephalopathy. But all this starts here, this acute, after all the prevention fails, and I believe it occurs at a very young age in the Indian population. Here in India, this is an acute anterior myocardial infarction. From the symptom onset, if you present within 60 minutes, there may be negligible consequences, but if you wait for 90 minutes to 120 minutes, there may be minimal consequences, but after 4 hours, there are substantial lifelong consequences. Now, you can also have the same patient once the scar heals, it becomes a slowly conducting area producing ventricular tachycardia, which would be the later manifestation. Acute monomorphic ventricular tachycardias are not due to an acute MI, they are usually healed scars. And an inferior MI, this is 28 years old. This is in Kerala. They say the arteries are extremely small and they get myocardial infarctions at fairly young ages. And this is an inferior wall or right coronary artery myocardial infarction. We also had this kind of an Indian man. We put him on a treadmill and he developed this, came for a routine treadmill test. And we had to shock him, all the patches fell off. Pretty scary day for us in the stress lab. And this is, all these occurs at very, very young age in the population here in India. Then I don't need to say why it is diabetes and hypertension. Everything is fairly common. It's not uncommon that some people unknowingly prescribe medicines which prolong QT interval, and you will have a long and a short cycle sequence in a QT interval. This used to be more common when erythromycin and Seldane or Benadryl were prescribed together, and unfortunately the patient developed torsade du pointes, and then they can basically die at home. It's equally common. I mean, I've come now for 6 years to the Whitefield campus. We do at least 20 accessory pathways each visit in 5 days. This is pre-excited atrial fibrillation, fairly simple disease. If you prescribe beta blockers and block the AV node, you could potentially the patient can die. So it takes about 45 minutes to solve the problem for good. So an ablation is a very good choice for these kind of patients. So particularly you should not be giving any amiodarone for patients. Either procainamide or ibutylide are the only drugs you can give in the emergency room for pre-excited atrial fibrillation. Now, in the Indian context, this was studied in Andhra Pradesh, right in this very state, the epidemiology of sudden death among residents of this place. You can see the chest discomfort before collapsing is very common. Uncontrolled hypertension is a major problem because people need about 8 to 10 grams of salt here, and if you're not sweating, you're going to have high blood pressure. Poor access to care, and interestingly, women die more suddenly without formal evaluation. Either the symptoms are ignored or they don't complain because they share the burden, they run the family, they don't want to complain and become a burden themselves. Cities have better access to care, which is already covered. Here's a very interesting data which Dr. Garg gave it to me, that they did a 451 people sample size we have 40 years old. At 40 years of age and above, about 60% already have coronary artery disease in this Indian context. So I don't have to emphasize that probably significant percentage of Indian population has asymptomatic coronary artery disease. Should we do coronary CT? And somebody was talking earlier about coronary CT angiograms, and you can see this even in the European population in Scotland. 4,000 patients were randomized, and it looks like CT angiogram definitely makes a big difference in terms of outcome. And you can see if you have standard of care or just adjusting medications, only doing angiogram at the time of worsening symptoms despite medical therapy, versus CT angiogram early, and if you find significant disease, going for interventions does save lives. And so I'm not recommending that everybody should get CT angiogram, but if you have early symptoms or exercise intolerance, just don't ignore it. Don't think it's just deconditioning. Get yourself tested, because after all, you're Indians who have much higher coronary disease. While the substantial portion of the sudden death prevention have been done in patients who are already sick, either from LV dysfunction or prior myocardial infarction, vast majority of people who die suddenly or have never had prior cardiac disease. And that is the biggest problem. So automatic external defibrillators have to be present in every village. And that's something that we, the country, can work on, and at least providing a single AED for each village. Every medicine you prescribe does produce a reduction in sudden cardiac death. So don't think beta blockers, angiotensin receptor blockers, and do they actually reduce? You don't have to have an ICD and a defibrillator to prevent sudden death. You can prescribe other medicines, particularly these statins have shown to reduce the number of shocks in ICDs, as well as the aldosterone antagonists. And this is what an ICD does. You have a monomorphic ventricular tachycardia. Within a matter of 18 seconds, you'll receive a shock, restoring the underlying regular rhythm. If you're fortunate enough to have a facility which implants it, it is very useful. But in general, all of the other medications can actually produce. So with that, I'm going to ask my panelists to get involved before I move on to the next topics. I want to start with Dr. Raman to say, what do you think are the most important measures in terms of Indian context for prevention of sudden death?
Saram, everybody. My most humble pranam at Bhagwan's lotus feet for bringing us in your midst today. It's a great honor and privilege for me. As to speakers before me have highlighted the importance of risk factors, diabetes, hypertension, family history, and also the role of education. In the Indian scene, as the data has been shown, there is a particularly high incidence of premature coronary artery disease and sudden cardiac death secondary to myocardial infarction below the age of 40. And so going forward, education is very important. So education on early recognition of symptoms, be it chest pain, shortness of breath, palpitation, syncope, all the usual things. So risk factor modification at the individual level is important. But then I'm going to pass it on to Dr. Garg regarding what can be done for prevention of sudden cardiac death as to in the community setting.
Sir, preventing sudden cardiac death is obviously a very big challenge for everyone. I mean, we are hearing that how a 39-year-old surgeon suddenly died suddenly. And we hear these stories, unfortunately, every day from every part of India. And India is, as mentioned this morning, is the world capital of coronary disease. So I think at an individual level, as Dr. Yegya-Raman just said, that it is very important that we diagnose, that we do not miss serious coronary disease or even early coronary disease and take care of it, take care of the risk factors. At the other level is at the community level, that ventricular fibrillation, cardiac arrest is going to happen whether a person in coronary disease, but there are a lot of non-coronary conditions where a person gets cardiac arrest. It could be simple things like electrocution. It could be somebody with some kind of metabolic problem or a drug overdose or some such thing. And these things need to be attended to, and for this, every person, able-bodied person, should be able to perform cardiopulmonary resuscitation. And at the same time, availability of automated defibrillators should be more and more present in those places where a lot of people are collected. Fortunately, while I was coming inside, I saw 2 AEDs lying outside. So obviously the organizers of this conference are aware of this fact that wherever people collect, there is a chance. And so there should be an AED present. There should also be, people should be able to do CPR. So I would even suggest that in schools, in high schools and all, children over the age of 15 or 16, all of them should have a CPR course, learn how to do AED and do that. Thank you, Sarah.
So besides this, so every day I'm seeing 40% cases belong to coronary disease. Under 20-30% is dilated cardiomyopathy of unknown etiology. And these coronary patients, most of them very young. And taking the history, we know that mostly the lifestyle derangement.
Yeah.
So lifestyle modification, that have been emphasizing on the education on lifestyle modifications is very, very important. So really many people don't know cigarette smoking is cause for heart attack. They know only cigarette smoking causes only the lung cancer. Yeah. So many people, even though they are some are literate, they don't know much about the smoking effect on coronary disease. Yeah. And second thing, so 40% cases, my cases, what I do a coronary angioplasty, they belong to the lower socioeconomic strata, and mostly they are daily laborer. And they are not only multiple disease, all the coronaries are calcified. Heavily calcified, we have to use the other innovative procedures to deal with the coronary disease. So asking them, what do we eat? Now, 3 times, as Dr. Mohan has emphasized today morning, 3 times only rice. That is the only source of energy to them. So we have to emphasize on the health education and especially on all the risk factors, and also some educated people also. Sir, if you start now medicine for hypertension, you have to continue for lifelong. So I thought I will stop it.
Yeah.
They come with the accelerated hypertension, mild hypertension. So education is very important to prevent the coronary disease, because coronary disease is the main cause of sudden cardiac death. Yeah. And third thing, once disease already started, patients come to the heart failure stage. So what the cause of death? Either pump failure or sudden death.
Yeah.
Isn't? So they are not taking the guideline directed medical therapy.
Sure.
Now our physicians are not, they're not enough probably exposure. We should have, the quarterly or half yearly some program to educate our physicians also.
Yeah.
We should educate physicians, educate the public. So that is the main focus of today.
Right. We also want to touch on the second epidemic.
Besides this, can I ask one question to you, sir? Sir, non-ischemic cardiomyopathy. Even though guideline writes that EF drops below 35% for primary prevention for ICD, what is your opinion on non-ischemic cardiomyopathy?
The degree of benefit in non-ischemic cardiomyopathy is reduced, but if the patient has functional class 2 or 3, EF less than 35%, it is reasonable. If it is functional class 1 patients, there have been, most trials have shown not significant benefit. In a resource constrained environment, I would avoid putting defibrillators in non-ischemic cardiomyopathy if their functional class is excellent.
Should you do MRI or do some other ECG, sort of ECG science there?
If you have heavy burden of fibrosis and MRI, there would be a consideration. Non-sustained BT and Holter monitoring would be a consideration.
But to the cord point, as this is same 15%. Isn't cord point in In any value, cord value, beyond this we have put
What is the question? sir?
fibrosis, the amount of fibrosis by MRI.
Fibrosis, yes. If you have a significant burden of fibrosis,
What is the significant, what is the definition of significant?
anything over 15%, particularly in the subepicardial area, would be considered very significant. But let's move on to the next topic, the atrial fibrillation, which is a pandemic in itself in the European community. It's also, ever since Michel Heiseguer from France described that most atrial fibrillation has a focal source, particularly in the paroxysmal phase, and we started doing, we have been doing ablations by putting radiofrequency catheters. But then came cryoablation, which is a straightforward and a quicker way of trying to isolate the pulmonary veins. And today we have pulse field ablation, where a high voltage energy is delivered to increase the number of pores, allowing calcium to enter the cell, and that in turn causes cell necrosis. So this has become, why are we choosing this method? Because the safety margin is substantially better, because the energy source required for the cardiac myocyte is entirely different from what is required for the esophagus or for the nerves and so on. So we have substantially high safety margins with this. So here, this is how we do it. This is a multipolar catheter. We put it in the left superior pulmonary vein. Within 2.5 seconds, the pulmonary vein is isolated. And similarly, this is a right inferior pulmonary vein. And you can see here too, it takes about 2.5 second applications, rotational applications about 6 to 8. So overall procedure time is now about an hour. What used to take 6 hours has gone down to an hour from nowadays. And this is the type of catheter we're using, and we continuously monitor it on intracardiac ultrasound. And we have some different shapes. We can use this catheter in a basket mode or in a flower mode to produce the pulmonary vein isolation. You would see that this is the back wall of the left atrium. You can see left superior, left inferior, right superior, middle, and inferior pulmonary veins. After this kind of deployment, you get kind of a low voltage scarred area. So sources from this location can no longer influence the behavior of the left atrium. We can do other areas, but most of the ablation is confined towards the pulmonary vein. You know, you can also do, we're running out of time, so I'm going to say in the Indian context of atrial fibrillation management, if you don't have access to ablation, then it becomes medication. If you have heart failure, don't use calcium channel blocker. Amiodarone is your good friend, but don't use more than 100 milligrams. It's the hemodynamically unstable, you may have a cardiorhythm, but if you are hemodynamically stable, you can control them with beta blockers. If you want to rhythm restoration, because the heart failure admissions are repeatedly occurring, then you can do cardioversion with low-dose amiodarone. We've not seen many complications with 100 milligrams. Once you go 400 milligrams, there's a 6% risk of pulmonary fibrosis. So we try to minimize the dose to 100 milligrams, even 5 days a week would be a very good option in those patients. So use beta blockers, amiodarone in heart failure patients, and if your patient has normal LV and no heart failure, you can use calcium channel blockers. And let me show you, because I want my panel to get involved. So here is ventricular tachycardia is often confusion in the emergency room, whether it's supraventricular tachycardia with aberrancy, but always look for the P waves. If your P waves are dissociating from what is the primary rhythm, then you are clearly dealing with ventricular tachycardia. As again, monomorphic PT is more likely from an old infarct, not an acute infarct. If your patient is in regular rhythm in the context of digoxin, consider this. Dr. Raman, what do you think of this abnormal rhythm? A patient in atrial fibrillation with very regular rhythm in the context of taking a medicine for controlling the ventricular response.
So this is a patient who has been on long-term or even intermediate-term digoxin. Anytime you see total regularization of the QRS complex with a slow rate, you have to think of complete heart block with underlying atrial fibrillation. And this very little safety between therapeutic levels and toxicity when you use digoxin. So that should be uppermost in your mind.
I'll just add one thing here while we're talking about atrial fibrillation, is that atrial fibrillation is a big reason for people having stroke. So it is very, very important, like stroke, we are preventing stroke, like especially in elderly people. Many times AFib can be asymptomatic, undiagnosed, and so it is hard to very seriously say everybody should get an EKG after, say, 60 or 70. But if you can, and if you have any symptom, one must get one. And the other thing is, nowadays, with increasing use of wearable devices, people are able to detect AFib. And AFib, if one finds AFib and one is beyond the age of 65, 70, strongly consider anticoagulation.
So all chest pains are not due to coronary disease, so it is reasonable. Can we look at the EKG, and maybe Dr. Dash can
just before that, pertaining to atrial fibrillation.
I want the EKG shown on the slides, please. Yes. So what do you think, Dr. Dash? This is a concave ST elevation, non-vascular territory, 24 years old, complains of chest discomfort, leaning forward, worse with deep breathing. So this is suggestive of not a coronary disease.
This is not an early fibrillation?
Say that again?
Early fibrillation.
No. This is very suggestive of pericarditis. So all ST segment elevations are not myocardial infarctions. So we just want to make sure non-vascular territory. And of course, this is more of a Thailand condition. I don't know how many patients have Brugada syndrome in Indian context to the shark fin ST segment elevation. These patients are often taken to the cath lab for an angiogram, but they do not have coronary disease. And they have a Brugada syndrome, which can cause sudden cardiac death. And lastly, we have leadless pacemakers, which are now available. We can put it for single ventricle, or you can even do a dual chamber with an eye-to-eye or implant-to-implant communication. I think we have 3 minutes left, so I want Dr. Dash for some closing comments on sudden death in Indian context as well as...
Leadless pacemaker. About the leadless pacemaker we are talking. Indian sudden death is most common is, let's say, coronary disease, most common coronary disease, where we see every day 150 patients in OPD, and inpatient also quite 100% occupancy. So many patients come directly with ventricular fibrillation with the shock stage. Most common is coronary disease.
So Dr. Dash, do you strongly advise people getting coronary CT angiogram? Young people?
In coronary disease?
Yeah, to detect coronary disease.
See, just I'm telling this, my nephew very young. So he told me 2 years ago, the uncle, I had my chest pain. So I didn't give importance to him. I did echo and ECG, everything normal. I left him. So few days ago, he told whole night I couldn't sleep because of chest pain. I did echo, there is inferior myocardial infarction. So in my opinion, actually anybody coming just some slight doubt, better set for a CT coronary or coronary angiogram. Because it is preventable. You can save life.
CT angiogram is
CT angiogram or coronary angiogram. CT angiogram is better than coronary angiogram because you know the...
Non-invasive.
No, not non-invasive. You know the work, the plaque burden plaque burden and the calcium score better. See, calcium they are there, but coronary disease is not there.
How much do you recommend stress testing?
How much?
How often do you recommend stress testing?
Test is...
stress testing.
Because I do not
so,
much.
So if you don't have CT calcium...
CT coronary use.
You don't have coronary calcium, high coronary calcium score, CT angiogram is probably a very good test to detect coronary artery disease. But I don't know how many people will have access to it in rural setting.
In that you say, I should have thought stress echo better than the stress electrocardiogram.
Well, we're actually right on time, so we're one of the groups who were just stuck to our time, but thank you very much. So we are, do you have any other additional comments?
Yes, I got, sir. As you know, lifestyle modification, every disease. See, must be knowing that ESC guideline, European guideline, water fibrillation, they use a lot of acronyms. In atrial fibrillation, AFKR, atrial fibrillation care, C for comorbidities, R for rhythm or rate, care, A for avoidance of stroke, R for rhythm or rate, E for evaluation. So comorbidities means obesity, hypertension, diabetes, these are risk factors for atrial fibrillation. So you have to give importance to those things. And you don't believe me, so few of the patients, they have history of sleep apnea. And we did sleep study, and gave them that CPAP. So after a few days, the atrial fibrillation revert to normal, sinus.
Yeah. Sorry, we didn't have time to talk about statins. Somebody else will address that issue, but with that, we should probably give the next speaker some time. So thank you very much. Thank you, my panelists. Thank you.